Hello and welcome to our 2-Minute EBP Challenge. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. Join us online by going to www.edfornurses.com. As I mentioned, this is part of our 2-Minute EBP Challenge, and today we're going to talk about the duration of asthma symptoms. The 2-Minute EBP Challenge can be found by going to our website, and right on the home page there you can sign up. Every Friday you get an email to your inbox that gives you a question. You answer the question, send us back a reply with your answer, and out of the correct responses someone wins a prize. That happens every week. If you'd like to become part of that, then send us an email or go to edfornurses.com and you can sign up right there. Another thing that's really exciting I'd like to tell you about is that we have a Google group called 101 Nursing Tips. If you go to this website here, groupsgoogle.com/group 101 Nursing Tips, or just go to Google and search for 101 Nursing Tips groups, you'll find us. So join us there online and become a member. Start posting some of your own tips so that you can get some real help with your practice. Today we're going to be talking about asthma and the duration of asthma symptoms in patients who have an exacerbation of asthma that's also called now an acute-on-chronic. Now, they're using this new terminology to give us some idea of the fact that the patient has chronic asthma and then has this acute episode on top of it. So when we talk about acute-on-chronic, which is the new terminology that they are liking to use now instead of asthma exacerbation, when we talk about acute-on-chronic, we're talking about the acute episode on top of chronic inflammation that's occurring with asthma. So what happens with asthma that causes a patient to end up having an asthma attack? Well, there's an underlying allergic cause to most asthma, which means that there is an allergy that's causing the airways to become hyperreactive. Now, it doesn't mean that it has to be an allergy that's causing the asthma attack, but the underlying allergy is what's making the airways be inflamed and be hyperresponsive. This causes inflammation, and the inflammation then causes bronchoconstriction and mucus production. Those are what cause the patient to have the wheezing and difficulty breathing. If you look at the diagram on your screen here, what it's showing is the airway, that's the normal one at the top, and then the one at the bottom is what would happen with a patient who has asthma. Notice we have both bronchoconstriction, so the constriction of the bronchi, and the green stuff in there is the mucus production. So we have mucus being produced, and mucus is also blocking the airway. So there's two things we're going to have to deal with when we're treating this patient. The bronchoconstriction, we're going to have to dilate that, and we also need to deal with the mucus production. So it's twofold in our treatment. The symptoms, there's a number of different things that we can look at that tell us that our patient is having an asthma attack. You can look at the pulmonary function test. You can look at inflammatory markers such as C-reactive protein, things like that. We can look for dyspnea. We can look at the sympathetic nervous system stimulation, tachycardia, hypertension, those kind of things. Accessory muscle use when the patient breathes, and also pulsus paradoxus. This is one of the rare situations where a patient can develop pulsus paradoxus. Pulsus paradoxus is a change in blood pressure with the patient's respirations. As the patient breathes in, the increase in pressure in the chest decreases venous return to the heart and decreases blood pressure. As the patient exhales, there's less pressure in the chest, more venous return, and the blood pressure will increase. In other words, when a patient has pulsus paradoxus, their blood pressure is going to change with the patient's respirations. Now, this is easiest to see when your patient has an arterial line in place. However, if you don't have an arterial line in place and you're just taking blood pressures, what you're going to tend to see is a widely changing blood pressure. One blood pressure, when you read it on your machine there, is going to be, maybe a little bit higher, 150 over 90. The next one maybe is 130 over 70. And you're like, what is going on here with these blood pressures? It could be that the patient is exhibiting pulsus paradoxus. The other way you may be able to tell this is by feeling the pulse. If you feel that the pulse gets stronger and weaker with the patient's respirations, they could very well have a pulsus paradoxus. Now, all of these objective measures of the patient's breathing are great, but the best evidence we have that this patient's going to stop breathing are the subjective things. So that subjective feeling of dyspnea is the best indicator we have that this patient is going to stop breathing. So pay attention to what they're telling you about their breathing. Our treatment consists of, as you might imagine, bronchodilators and steroids. So you want to open up those bronchi. That's what's helping right now. Steroids are what's going to help tomorrow. So steroids help to get rid of the inflammation. That's what's going to help tomorrow. IV magnesium has also been used in asthmatics. Magnesium is a relaxant, and by giving it to our patients, we will cause bronchodilation by relaxing the bronchi. Keep in mind, though, that magnesium is a relaxant, and it also relaxes the cardiovascular system, so your patient can end up having bradycardia and hypotension. Now, that's not usually a big problem in our asthmatic, because most asthmatics are going to be hypertensive and tachycardic, so that's probably not going to be a big problem in your asthmatic, but it could be. So we want to be careful with using IV magnesium. Obviously not a first-line drug. It's going to come after our bronchodilators and steroids. However, there are some research studies being done right now using magnesium as an aerosolized drug. So rather than giving the patient the typical albuterol or Zopanex or whatever we're using in our aerosol treatment, instead now what they're using is magnesium. So we're still finding out some information about this. It's not kind of ready for prime time yet, but it's getting there. Antibiotics may be necessary. A lot of times what causes this acute-on-chronic asthma is going to be an infection, so antibiotics may be necessary. If we need assisted ventilation in this patient population, we would probably move right to intubation and mechanical ventilation. If you're going to use BiPAP, use it cautiously, because BiPAP can hide the problem and the patient crashes suddenly. In addition, BiPAP is blowing air into the lungs, and with the air trapping that occurs in asthma, your patient can end up having way too much air in the thorax and cause cardiovascular collapse. Be careful with BiPAP. I've seen it used effectively in asthma, but it can be a problem too. Anxiety control may be necessary in this patient population. They're used to breathing normally most of the time, and then suddenly they can't breathe. That's a type of a patient who could have a lot of anxiety surrounding this event. Immune modification and allergic modification are the things that are going to treat this long term. Now, inflammation is going to occur and cause bronchoconstriction, which will clear pretty quickly. You give the bronchodilators, you give the steroids, etc., and that's going to clear up pretty quickly. But mucus production may take several days to clear, and that's why a lot of times in our asthmatic we're going to see symptoms lasting longer than we may expect. In this recent study, what they found was that 11% of patients had symptoms that lasted less than a day. About 45% of our patients had symptoms lasting 1 to 3 days. So that's going to be the most common. The patient comes to the emergency department, we give them the bronchodilators and steroids, send them home. 1 to 3 days, patient feels better. But 12% of our patients had symptoms lasting from 7 to 13. 7% had symptoms lasting 2 weeks or more, and 6% had symptoms lasting greater than 3 weeks. So all total, 25% of your asthmatics have symptoms that last longer than 7 days. So even though the vast majority had their symptoms lasting less than 3 days, there is a big group of patients who have symptoms that last longer. So we do want to be aware of that, and we want to do some patient teaching to make sure that our patients are getting the treatment they need. So patient teaching about the length of symptoms and how long they could possibly last, medication administration, why it's so important for them to take their medications as directed, symptom prevention, and by cleaning up the bedroom. That's one of the best ways we can try to prevent symptoms of acute attacks in our asthmatic. By getting rid of the allergens in the bedroom, or that's the one room in the house where you spend more time than any other room. So if we clean up the bedroom, we can decrease the amount of hospital admissions that occur in asthmatics and decrease the amount of medication they use. So that would certainly be a good way to try to prevent or decrease the symptoms that the patient has. He says, well, your breathing tests would be normal if you were 3'8" and 150 years old. All right, so we don't want our asthmatic to get into that kind of situation. We want our asthmatics to have good breathing, and we don't want them to be in the hospital and in and out with a revolving door kind of thing that happens with a lot of asthma. So in order to do that, we want to make sure that the patient has a good relationship with their physician so that they can call the physician, they can get changes to medications as needed, and that the patient is compliant with their medication. medications. A lot of the ways we prevent the acute attack is by treating the chronic asthma with the inhaled steroids and with the other medications. So we want to make sure that the patient's compliant with that, how important that is to try to prevent that acute attack. If you want to find out more about this particular study, you can find the article by going to medscape.com/view article 753484. This is an article by Dr. Blyce and Associates that was presented at the American College of Allergy, Asthma, and Immunology 2011 Annual Scientific Meeting. Remember, too, you can get free nursing tips right to your cell phone by texting nursing tips to 86677. So in the to line on your cell phone, you'll type in 86677, and then in the body of your message, type in nursing tips, and it'll come right to your cell phone every week. You'll get another nursing tip right to your phone. It's that easy. Keep in mind that your carrier may charge you for text messages that you receive. I want to thank you for joining me this week for our 2-Minute EBP Challenge. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. Join us online by going to www.edfornurses.com. Thanks again for joining me this week, and until next week, bye now.